Thanks everyone for your time today. I'm sorry, I've had a cold, so I'm a little bit hoarse. And my talk is Are We Staying on Our Feet with Falls Prevention? I'm afraid the short and very blunt answer is we're not, but I hope we can do something about that in the coming years. Falls really remain a substantial socioeconomic problem. And we have special groups, when I say special groups, where there's not strong evidence for. That includes hospitals and residential care, but also people with strokes, people with dementia. There's less strong evidence about how to prevent falls for those people. But importantly, we need to translate the good evidence we do have into practice, and we don't have enough translation research, I don't think, going on with that. And we also need to, I think, really work hard, much harder in the health promotion area for everybody over the age of 50 to really directly communicate the message about falls prevention. If I just try to give you a very quick overview, and if you work in the area of falls prevention, you can simply pull out stunning statistic after stunning statistic to talk about the size of the problem everywhere and anywhere around the world, really. Over the past 10 years, the age standardised rate, so that's allowing for more older people, of falls injuries has increased by 2% every year. So in 1 year, 2010-11, we used 1.4 million patient days just for older people coming to hospital with an injury from a fall. So think about that amount of money for a minute. If we want to look at Australia and we think that car accidents are a large problem, and of course we do want people to drive safely, but if we want to think about a slightly larger problem, then just move on to falls prevention. Of course, falls is by far the biggest injury problem that we've got today. If you're thinking Western Australia is doing well, we're not. Look at our statistics here since 2003 to 2012, our falls rate has noticeably increased in the over 65s. So we have more people falling over and injuring themselves on top of the already very large number of people we had falling over and injuring themselves. Let's remember that 70% of falls occur in the home or in aged care facilities. But also, let's not make us think that that means we can relax, and those of us who are over the age of 50 sitting here can think, well, that's great, when I'm older I'll do something, because the problem with injury prevention is you need to do something before you have the injury. And that's the crux of the problem, isn't it? That a lot of us are waiting until we've had the injury or we've got an osteoporotic fracture before we think about falls prevention. And, why is it so important? Just simply because of the absolute negative sequelae of falls prevention. And I could give you an hour-long talk just talking about all the negative consequences of falling over. And yet, continually, surveys show that about 3/4 of people over the age of 65 don't think they'll fall over. My research is all about talking directly with older people, and in my research, I constantly meet people who tell me this. And this is a young man of about 65 in hospital. And when I go up to talk to people to enrol in our studies, and I say, well, part of my study is that I'm going to tell you a bit about falls prevention and hopefully give you some ideas about how you can prevent falls. And if people have had a fall, they will say, I wish I had met you before. And I did have one Italian man in very broken English who'd broken his leg from a fall. And long after I was able to escape from his room, after he very cheerfully completed the survey, he followed me out and down the corridor loudly saying, everybody should be told this, you must tell everybody. And he could have been a great salesman for me in future research projects, but people find out afterwards. There is good evidence about falls, and that's really what I want to focus on today as well. Are we translating the evidence there is? So we do have excellent evidence that if you do good exercise programs, you can significantly reduce your risk of falls. It's one of the most effective ways to reduce your risk of falls. which is logical when you think about it. Better balance, more strength, more coordination is going to reduce your risk. But what do we know? We know in Australia that once people get to the age of 60, about 50% to 60% of people are insufficiently physically active. And we know that as people get older, that really increases. So the very people that we would like to be maintaining healthy ageing are actually not doing that. We also know that there are other good interventions you can do to prevent falls in your own home. And yet we know that there's low uptake of those interventions. So we know that lots of people don't like putting a rail in their home, don't like changing the adjustment of their door, don't like changing any of their habits or practices about the way they're storing things, perhaps in their kitchen. So we know that people aren't taking up those messages. And ourselves, particularly our research team, is interested in looking at falls after hospital discharge because we know that's a big problem. So we're working hard to try and really bridge that gap between evidence and practice. And we know that older people think falls are something you just don't talk about, you get a bit embarrassed about. If you fall over, that just shows you're being a bit silly. Whereas really, as health professionals, we want to get the message much more broadly out about what people should be doing. So we've been working really strongly with older people and actually trying to bypass the medical system now. So I really think we need to give up on the idea of waiting for people to have some sort of discussion with their GP about falls prevention. It needs to be much, much more broadly based out in the community. We've been doing a lot of education, translation and trying to work directly with groups of staff and older people about falls prevention. We've been doing some peer education projects, peer buddy exercise, and I'll just give you a quick rundown very briefly of some of our programs. One of our programs completed after undertaking a lot of foundational work is providing older people who are already doing strength training to be peer buddies to other older people who aren't. And that's been very promising, and we're looking at expanding that program. We have been looking, we've provided over the last couple of years, a community of practice translation program for people in a large residential setting, and we've been getting them to translate falls prevention evidence into practice there. We've been holding large forums. This is a World Cafe forum. We're holding another one where we gather older people together and talk with them directly about how in WA can we disseminate the message and promote practice change. And this was the response we had to that World Cafe, so people just loved it. We also have been training with ICWA, our collaborators, peer educators, to go out and talk to groups of older people and get them to take a personal action plan. And that's been a very successful program. I just want to talk to you about this transitional care for a second. We know that when people go home from hospital, they fall over a lot. This slide looks very complex, but it's just part of our 13 sites when we've been doing our community of practice. And if you look at the falls rates there, we started our intervention around about phase 3. And we noticed that when we pulled out our 2 transitional care sites, this is what happened at about phase 3 when those facilities changed to transitional care. So you can just see that when people go home from hospital, they are at high risk of falling over. So we're looking at working on some projects to say how can we strengthen transitional care so that when people go home, they actually get the rehabilitation they need, they can return to their normal self. And we're also trying to undertake now a new project looking at let's get people before they go to hospital, if they're going for an elective event like knee surgery, and give them some prehabilitation. So they arrive in hospital prepared for their event and they don't think that I'll lie in bed and then I'll just go home and I'll magically be better. We're also conducting a project grant and Leon, who you heard speak earlier today, is on our project team for this also, where we're looking at working with older people before they go home from hospital and when they go home. We've just finished recruiting our 390 participants from around the East metropolitan area of Midland and Armidale and Bentley. And we've been giving these people some structured support so that when they go home they've got more help, we hope, to know really what they can do to enable their own recovery. So we're continuing our collaborations with all our collaborators. We're also doing some training and helping people how to get up off the floor when they do fall over. So we're sort of working directly reaching out to older people. So in summary, I would just say, falls are one of the biggest problems older people face. Yet, paradoxically, the very things that prevent falls are the things that promote healthy ageing. So if we could link that message directly to older people, we would be doing a fantastic service to ourselves in preventing injury, but also in maintaining healthy ageing. And I have to advertise at the end, we've got a new World Cafe coming up, and we're seeking 100 people, anybody over the age of 50. If you have anyone back in your organisations who you would like to send along to join in our discussion, we would really seriously welcome them. We have some videos that we've made regarding falls prevention, and we'd like to get feedback from community groups about those videos. So please come along and join us and have a free lunch. Thanks, everyone.
If I remember correctly, Jane Barrett's public lecture, I think she said that falls have been identified as the key precipitating factor in, significant decline in health for older people. So she linked a fall to all sorts of things like influenza, for example, because you become less mobile and then you get sicker. And so, really timely message. Comments, questions? Yes, 1, 2 to start with.
You said that 75%, hopefully I've quite the right numbers, take place either in the home or at the aged care facility. Has there been any breakdown of that about how much occurs inside the house and how much occurs maybe outside in the garden? Because the paving surfaces outside in curb heights and garden beds and level changes and things like that, it'd be interesting to see if there is numbers that could be split into.
Yeah, there are some figures on that. I don't remember them offhand, but the Australian Bureau of Statistics does do all those figures now. The majority do occur inside, but we've shown in a couple of our studies, and there's also studies in America showing that less mobile people fall inside, obviously getting out and about a little less, but more mobile people fall outside. But it is surprising that even people that you would think people are falling down the shops or going for the bus, and there are some people doing that, but most people are falling outside in their own garden or just on their own footpath. So it's probably about 60-40, but I wouldn't confirm the figure without being able to look it up.
Christine?
Just a couple of comments. When we did an exercise probably 18 months ago now to understand what our biggest safety risk was in the city, it was falls. Yeah. And I think there was an element of surprise amongst people when we learnt that, because we probably had other ideas of what that could have been. The other thing we've just started to do around reducing the barrier for participation in active exercise with older people, like in our local government, is we notice that when people get to 65, their membership to our gymnasiums and our sporting facilities really declines. One of the barriers is cost. So we've now introduced this scale, and it'll be interesting to see how it goes, that you get a 60%, I think it is 60% discount at 60, 70% discount at 70, right up to 90% discount at 90.
I think this is really important, and
we'll see how that goes.
I think it's vital. We've done extensive interviews on this, and we have found that cost and lack of social support is a big reason. And I think that local councils that have more overt age-friendly policies like this, it's going to be tremendously beneficial. Yeah.
There were at least 3 hands, so we'll hear all of the questions so that we don't run out of time before we get them. So one there.
Well, Christine just kind of touched on them a few minutes ago, but I just thought it was worth mentioning. I conducted a community engagement and consultation for the development of an age-friendly plan for a local government last year. And when we put out the survey, there was a question on the back of the survey: what's your 3 key priorities for this catchment area? And community safety was coming through as number 1. And it really surprised me because when I went to look at the crime stats for that local government catchment area, they were really low. It was one of the safest local government catchment areas around WA. So I was thinking, what could it be? So when we actually done the facilitation workshops, we were able to drill down into that. It was actually perceived community safety. It was the fear of falling outside. So people were actually being socially isolated and confined to their homes because they had a fear of falling when going outside. So you can see, like, it may only look like a fall, but then, you know, when you look at actually what that, like, what barriers that creates for an older person, it can be profound.
Yeah, the hospitalising areas is just tip of the problem.
Sorry, I've become a bully at some point. Two more questions, I think there were. Yes, and then.
Are you examining how retail spaces can be used, like mall walking, how that can be used as a space to spread the message?
And one more?
And falls prevention in the community. I think your presentation focused on people pre or post-op, or people who were currently in residential care facilities. Obviously, in the community, the goal is to keep people as fit and healthy and on their feet, so that they're at reduced risk of residential care. So just interested in falls prevention in the community setting.
Were there any others? Comments? Okay, so.
I'm sorry, I don't remember the first question. What was your question?
About retail and tapping into that.
The concept of using more walkers is a strong concept and really helpful. One of the things that we're interested to, though, think about is that exercise needs to involve more than just walking. So we're really, the idea of more walking is fantastic because it's so safe. But what we're really happy with is to see some of the more walkers incorporating balance exercises. Win-win. And in terms of community, definitely community falls prevention is all about exercise and all about home safety. So those are the things we need to, though, convince people to do them before they fall. That's the big issue. So people getting a little bit older and falling. And one of the things whenever I meet older people in retirement villages, they often will mention, I wish I could get out and speak to my younger self when I was in my 60s and start doing some exercise then, because then they're faced with trying to do it when they're maybe in their 70s or 80s. So it's start exercising when you're 50 if you haven't already, keep it up when you're 60, keep it up when you're 70, and so on. But there is other things to do with falls prevention as well, like, you know, vision is a good example. Our biggest problem at Curtin, our biggest adverse event at Curtin is falls. That's our biggest problem for our safety committee. Curtin, you know, it's the multifocal capital of the world. All the academic lecturers with their microscopes using their bifocals and coming outside and tripping over. So just things like, you know, having good vision care and wearing the right sort of glasses, things like that are really important, and I think some of those messages are just not out in our community where they could be. So we'd like to get those messages out there. And then as researchers, we go back and focus on learning something else about falls and translating that out there as well, I guess.
Do you have time for, how we go, Carmen? We're actually finished. Oh, one more, yeah, let's go.
Could we add an element of mindfulness to locomotion? You know, being totally present in the present moment, so that people are more aware of their environment and what they're doing?
I'd like to do some research on that. I think it's an element that we need to look at. I think at the moment, what worries me is that when you ask people, we've had this overwhelming amount, 2 or 3 large studies, when we ask older people why they've fallen, they say, well, now I'll just be more careful. I won't go outside, I won't do this, I won't do that. So we don't want people to be mindful in the way of, I must be careful and move slowly. We actually want them, as the last speaker very put so well. We want them to maintain their brain connectivity and keep their good balance and going out and about. So I'd like to take that concept further. That's a good point.
Thank you very much. That was really wonderful.